We are live.
Well, thanks to everybody for being here today. I want to note we do have a quorum is present, and I want to make sure everybody knows we are streaming on YouTube. So at this time, I'll ask for a motion to approve the minutes for the August 27th, 2025 committee meeting as presented.
So moved.
Do I have a second?
Second.
Any opposed? Any abstentions? Abstentions? Okay. All in favor?
Aye.
Information, I'll turn it now over to Dr. Golub. So he's going to give us our starting patient experience story for the month.
Good afternoon, everybody.
October.
Before we get started, we always like to ground ourselves to our true north, that every patient we touch will receive equitable, safe, high-quality, patient-centered care to afford them the ultimate patient experience. So as you said, we have a patient story today, Jen, so if you'd like to introduce that.
Thank you, Dr. Golub. So today we are featuring Dr. Maria Antonelli, a rheumatologist, and our shared medical appointment for osteoporosis. To provide a little background, shared medical appointments offer benefits such as increased patient support, education, and improved health outcomes from peer-to-peer learning through shared experiences. So with that, let's hear from our patients.
We tested this, not here though. That's what I was afraid of, have faith. So we're gonna have to see if my volume will.
You want to, if you stop sharing and reshare and share your audio.
Okay. Stop sharing and reshare.
And make sure you check the little checkbox that says. Yeah.
There's a little share sound.
Yeah.
Try this again.
This is what creates the ball and glove of your shoulder. Remember we said for Janet, the hip is like a ball and glove. It's the same thing with your shoulder, right? So it's going on. Then this gets pulled.
I started doing the shared medical appointments last year. You actually get to see Dr. Antonelli more, and then you learn that you're not the only one that's going through like the problems that we all have.
You had one dose of half Evenity of 105.
I mean, I can't tell you how beneficial it's been. I get in to see her once a month, which is good, because if I have any concerns or whatever, I can bring them to the appointment and we address them.
So even though I'm only getting maybe 10 minutes about talking about what my issues were, I feel like I'm getting a 2-hour appointment, because all of these people, she's talking to all of these people with medical information that I may not have even thought to ask them.
I mean, I think we've all learned so much.
And so even if you have a 1-pound dumbbell or a 3-pound and you did exercises just sitting down, that's better than nothing.
I was much bigger when I first started, and I was intimidated by going to the gym, even going to therapy. And she said, no, Mary, you have to go. And I started out with a 1-pound weight, and I just moved on from that, and I started going to the gym, and I love it. Now you can't keep me out of the gym.
So I need to tell my muscles to pull the sugar in. And how do you do that? You walk. And you walk and you walk.
I've learned from every slide, and I have learned from other people, which has really made a big difference to me. So I think my quality of life has changed, made me much more aware of what I need to do.
It also helps you to make the decision as to what medication to take, because you hear from other people what side effects, what benefits. It really does help you make a more informed decision.
And she doesn't make the decision for you.
Right, and you feel more comfortable with the decision that you make.
I've been seeing Dr. Antonelli since day one she came to Metro. I loved her since day one. She is phenomenal. You just can't get a better doctor.
I've been coming to Metro for 45 years, maybe. I mean, all of my Metro experiences have been really good, and my doctors are all really good. But this is one of the best experiences I have ever had.
We empower our patients.
This is what creates the ball.
Well, thanks for sharing that patient experience story video. Now we're gonna turn over to the live presentations. I'm sure Dr. Ray and Ms. Mack are gonna provide the annual infection prevention update.
Is this okay?
Yes, ma'am.
So yes, I'm an infectious disease doctor. My name is Amy Ray, and Ron D and I have a shared history in which he used to call me the QOP, which was Queen of Pus, Pestilence, and all things generally putrid. And I thought about getting vanity plates.
Mike Anderson gave you that.
Yes, he did, but it caught on very well.
I thought I was gonna give you the four Ps.
I love it. Yeah, so I've thought about vanity plates as QOP. But I haven't gone that far yet. So it's a pleasure for me to be here this afternoon to share with you our world of infection prevention. And really our goal in infection prevention is we want to prevent every infectious complication related to care across the continuum of care. And so when I think about that as a healthcare epidemiologist, I think about things that are horizontal interventions. So every patient, every time, and more vertical interventions, selected patients, more process metrics for patients at risk for particular kinds of infection. So the fundamental cornerstone of infection prevention is hand hygiene. And so our goal is 100% compliance. The Joint Commission's goal is 90% compliance. Many studies have been documented across the world looking at healthcare workers, and generally the compliance is in the 40 to 60%. We are continuously in the high 80s, and we have a few items that I'm quite proud of. The number of audits that we collect annually is about 8,000 to 12,000. There's a range there. We are able to collect audits in the inpatient setting and the ambulatory setting. We understand that the risk is actually higher for inpatients for healthcare acquired infections. But I'm also particularly proud that our culture is such that those who are collecting the audits can provide point of care feedback, and that feedback is received well. So this is an intervention to prevent transmission of pathogens from person to person. Next slide, please.
No, this is.
Yeah, please.
My question is really how you measure this compliance. You referenced audits. So tell me how this works. How do we know?
So we have a group of providers and practitioners and nurses across the system who collect the data by observation. So on every floor, we collect a certain number of observations per month, and we aim across disciplines so that we capture, how the doctors are doing, how respiratory therapy is doing, and we can slice and dice the data that way to look to see, what group has had the highest performance, what group has room for improvement. We can look by floor. Of course, there's a Hawthorne effect. So if I go and observe you, that people always do the right thing and they apologize to me for things they haven't not done yet. That's the way that goes. So we have some Hawthorne effect in the data that's sort of inevitable.
It's random unannounced surveys.
Random, unannounced.
The only problem is once Joe goes to a floor and stands by the sink, near the sink, Joe doesn't ever go on that floor because it's the OBGYN floor. They'll know that he's probably observing for hand washing, and that's where you get the Hawthorne effect.
That's right.
What's the song du jour while you wash your hands now?
Oh, it's still happy birthday
Still
to
happy
you.
birthday? Okay. You have to wash your
Twice.
hands, sing two verses of happy birthday. It used to be Yankee Doodle, but.
Yes.
It's not in the guide of the
No, they already haven't been for a long time
Yeah.
ago, but Anyway, to continue, good question. So it's, I mean, most institutions are doing random unannounced audits, but as soon as an audit team goes up there and they don't belong on the floor, the floor figures out pretty quickly and then word gets spread, but it does drive up compliance.
It does rev up compliance. So when we look specifically at hospital-acquired infections, we include the types of infection in this data that are included in our patient harm reduction score, and we strive to prevent these infections because they are associated with increased length of stay. They can be associated with increased morbidity and mortality. And so CAUTI is catheter-associated urinary tract infection. So a patient developing a UTI as a sequela of acute care. What you can see from the data is that we will have months where we have 0 infections, and we will have months when we have 1 to 2 infections. And we like to look at the rates over time, but I also like to look year over year, comparing our facility to others within our NHSN network in terms of our standardized infection ratio. And so we are still, year to date, we've had 15 infections, and NHSN predicts 19 infections. So we're still performing favorably to NHSN, but we do appreciate that we have some room and opportunity for improvement. And specifically, we've had a little bit of uptake in utilization of Foley catheters across the system. So when we really dive into the data, our catheter utilization is up in the non-ICU settings, about 36% compared to 2023. So when we look at what we can do to move the needle and improve our rates, we can and do huddle on every one of these CAUTIs so that we can learn from it. We are more aggressively implementing and utilizing chlorhexidine bathing in patients, which reduces the risk of bacterial colonization, contamination of one's skin. And we can now spend a little more time focused on the units where our utilization is uptrending, because the key to reducing CAUTIs, without hesitancy, it is not only process metrics, it's mostly getting the catheter out.
So I'm assuming you have nurse stroke protocols and Epic catheter discontinued after 24 hours.
So we have for years, and what we've learned recently is that we had about 8 of them. And so what was happening is confusion. Yeah. So what we've done is consolidate and simplify with our IS partners, our clinical informatics partners, to simplify the process, to engage nursing, to, so that they're more familiar with one order set or a couple of order sets rather than 8. So there's been a lot of energy around CAUTI prevention. We were very successful. We do have room for improvement, and we do have some next steps to take with that.
How about deployment of a software plate catheter device that didn't exist when I was at the bedside?
Yeah, so we have both female and male external catheter. They're not catheters, they're collection devices is the right word. And we have employed them throughout the hospital system and the hospitalized patients. And we can bring back some utilization data here.
No, I'm just trying to lead the speakers.
Yeah. Yes, we are all for those non-invasive collection devices. They are a little bit work intensive, I would say, in terms of.
That's fine. I mean, so you've got alternative strategies, and I'm sure when Magnet comes, there's probably some clinical work that's been done by Dr. Mori and her team for the Magnet survey that shows improvement in those reduction numbers.
Yeah. We haven't. Actually, we're using a tool for just-in-time audit. So patient who has a catheter, is it below the waist? Does it have a cast secure device? All those things. Is the order set being utilized? So yeah, our goal is to get them out sooner.
So time and time again, that's the simplest way to get this rate down. if we transition to CLABSI, which is catheter-associated bloodstream infection, traditionally Metro, I'm very proud, has been a low utilizer of central lines compared to others in our NHSN cohort. And our SIR is 0.56. We've had 9 year to date. It's my job to dive into these individually and look at what point during the life of the catheter did infection occur. And it's about 50-50 early on, which implies we have room for insertion improvement, versus after the catheter's been in a longer period of time than 7 or 10 days. We have some room for improvement with educational efforts on catheter maintenance. But essentially, we do quite well with this metric. Next slide, please. And colon surgical site infection. So this is one which probably merits some explanation. We are sitting at 5 year to date through Q2, and we're predicted to have 4. And historically, if you look at our rate here, it's about 3.4%. If we had graphed this out longer ago, about 5 years ago, we were having rates of 16% and 9%. So we are making tremendous strides in this way. As an infectious disease doctor, our rate of 3.4 when 3 out of the 5 are gunshot wounds to the abdomen is actually really impressive. It might not appear that way by NHSN. I think our SIR there is more than 1, but for what we do and the services we offer to the population we offer, infection is complicated. So when a gunshot wound occurs, the host hasn't had time to mount an infectious response, but the injury contaminates the abdomen. And so these are patients at incredibly high risk of infection. And despite all of our process metrics or measures, we can only reduce that risk so much. Now, our hysterectomy infection rate, we have a low volume of those. We've made tremendous strides in those. We've had 1 infection year to date. So I think that is a success story. With MRSA bacteremia, hospital acquired. C. difficile is next. So we're doing fairly well with this metric. This is an infectious diarrhea that can happen in the hospital setting when the patients have had antibiotics, which then put them at risk for overgrowth of this particular bacteria, which makes toxin and can cause real havoc in a human host. So we watch this one carefully. This is all of these metrics, I must say, are improved through multidisciplinary processes with environmental services, with antimicrobial stewardship, with our nursing colleagues, with infection prevention. So this is one that we can, as I said, this is it. We keep a close eye on this. We're still not where we want to be in terms of our true north with 50th percentile by NHSN, but we are downtrending, which is phenomenal. And then this is the one that the MRSA, which is methicillin-resistant Staphylococcus aureus bloodstream infection. This one is a little tricky because a lot of the Staph aureus infections that we see are coming from the community, but it's also a bacteria that lives in the hospital. So when I look at these 12 cases, they are hospital acquired infections. So the things that we can do and we are doing, and I think Claire can probably speak to this more eloquently, but this year in 2025, we have implemented chlorhexidine bathing in a more widespread manner to decrease the amount, which is particularly effective. It's a fancy soap that decreases the amount of staph on the skin. So for hospitalized patients who have catheters, urinary or bloodstream, and for hospitalized patients who are in our ICUs, we recommend daily bathing. It's a pre-warmed cloth bath, disposable cloth bath to decrease their risk. And so Some of those interventions just went live as recently as August 25. So I'm hoping that as a more horizontal intervention, we'll get some rate reduction with these as well. And then finally, this is personal protective equipment compliance. So infection prevention is hand hygiene. It's doing the things that Dr. Morey mentioned, keeping, Foley bags below the level of the bladder, but it's also wearing gowns and gloves or masks and respirators when a patient's in isolation precautions. And so as we moved to GLIC, we had a real concern about PPE availability. We've alleviated our concern time after time. When we do our audits, we have the appropriate PPE, including every size of respirators, which is fantastic, outside of each patient's room. We know we have room for improvement with the compliance. And so our infection preventionists reach out to, as they're rounding and taking these audits, they give feedback at the point of care in a professional and friendly manner to increase our compliance. And then finally,
Is there a national benchmark for the percent of personal compliance?
There's not. This is sort of a Amy Ray said we must do this kind of thing. But it's not, when people have looked at it, it tends to be 40 to 60%, just like hand hygiene. It's one of those that people get really fatigued at doing. But is important in terms of pathogen transmission interruption. And then just finally, we've spent a lot of time talking about healthcare associated infections, but the infection prevention team does a lot of other things. And I'm just going to highlight two. This year, as the rate of immunized kindergartners in Cuyahoga County is now less than 90%, it's about 88%. Year over year, it's falling. Our surrounding counties are falling. We've been looking on the lookout for measles cases because measles is the most contagious infectious disease and could wreak havoc potentially in areas like our neonatal intensive care unit where those patients are too young to be immunized. So we have a infection prevention plan, again, multidisciplinary plan, and this is something that as immunization rates drop, we are expecting to see, unfortunately, vaccine preventable illnesses more commonly. And I'm, an infectious disease doctor with more than 20 years experience. I've never seen measles, but now I'm on the lookout. The other thing I'd just like to highlight is that my team does this fantastic job of working with high-level disinfection to keep our procedures safe for all patients across the continuum of care. But I would like to just say that they go the extra mile by streamlining those processes and really optimizing and simplifying them. So they not only audit them and provide the quality oversight, but they really get in the nitty-gritty and do a fantastic job of that. So with that, I'll be happy to take any questions yet.
When I've been in the cafeteria, I observe a lot of caregivers and they're in gowns, many of them. I pondered the idea that cafeterias have got to be one of the most bacteria-ridden places anywhere, period. So what's the practical borderline between a worker working, eating lunch, doing whatever they need to do in the course of a normal day versus the clinical requirements of cleanliness? I see that as a sort of an intersection, more burdensome here than most workplaces. Does this make sense, the question? So I guess the question, how do you reconcile this?
So it's a little bit tough to reconcile because it really depends on where the employee is situated in their workplace in terms of, if they're in a semi-restricted area, they're in scrubs and booties and those gowns that they wear in the cafeteria and that incidents are okay.
Yeah, my sense would be, and I think I know you've seen, is that they're wearing those jackets that are actually usually worn in semi-restricted and restricted areas.
Well, I'm not sure what I'm looking at, but.
Yeah, that's what I think that they are, and I think that they, in that moment, are protecting their scrubs when they're outside of their restricted space, because they are wearing those hospital laundered scrubs and are
in a way being compliant with our hospital surgical type policy.
Well, my assumption was that not everybody has to be as concerned as many in a hospital, because you mentioned that the nature of the work and where they are. And I was trusting that that was the case and there was a recognition of that.
There is an optics piece to it though, right? Like I see what you're saying and.
And those
looking at
gowns
that,
that they typically are using are disposable, so they throw them away once they're back in their space. So for example, the policies in the hospital is I can't walk out of the operating room or walk around the hospital with scrubs. I have to have them covered because I'm gonna go back into a sterile environment. So those are the types of things you're seeing.
I have a different question. So with the reduction in immunization rates and potential increase in prevalence in measles, which is probably one of the most infectious diseases that that exists. You know, is there a housing plan from the emergency room to wherever they go so that they're segregated? So I know you were Metro was the Ebola facility during the last Ebola outbreak. So I'm assuming you have a measles-like plan that's equivalent to what was done with Ebola. Because as they come in, they're going to shed, and if they come in the general population, you've got a greater risk. So I'm assuming with measles and diphtheria is making a comeback.
So
pertussis.
measles is an airborne spread
Right.
disease, and if I had measles, all of you would be at risk because it stays suspended in the airways. I don't have measles, but so we realized that most of these. So we have followed sort of where a patient would be coming from, typically either primary care office or into the emergency department, and we've educated the emergency department urgent care staff to recognize fever and rash. And fever and rash in an unimmunized child equals strict airborne and contact isolation.
And negative pressure room.
And negative pressure rooms.
So what's
Now,
the inventory of negative pressure rooms?
we have
two per like unit each
So
side,
what's the
so
total?
4 per floor. Ooh.
4 per floor.
and 2 in the emergency department at Maine.
Maybe more than that.
Okay.
So far, we've not had to, of course, with the we rapidly exceeded those rooms during pandemic times. Dr. Hecker and myself have now educated ourselves about fever and rash in children. And so we take a couple of consults electronically a week to make sure that these kiddos that we're seeing don't.
We're more interested in, or I'm pushing
Process.
the concept of process for planning for increased numbers. So we weren't prepared for Ebola. Your PPE inventory was insufficient if we truly had an Ebola outbreak in the US caused by somebody bringing it over from Africa. We know, that measles is going to spread as the immunization rate goes down. So I guess I'm making a push for you to think about the planning for if there's 2 rooms per clinic got overwhelmed, how would you manage that?
And we've done a little bit of that, like we've done if our ED's overwhelmed, if our units are overwhelmed in terms of patient placement and door closure and those kinds of things. And we've considered things like not putting patients who are infected near a NICU, for example. So that might require
The
some
other piece of
shuffling.
that though, ESPR funding is gone. So the question is, what's your inventory of your N95 masks and your
Thank goodness we are very, very robust in that because
until you do the calculation every time they break seal. I'm just gonna say, my only ask is not today, not tomorrow, but you add it to the list of work that you're gonna do planning for that because we know it's coming. As the immunization rate goes down, it's gonna put a strain on the institution. So enough said.
No, and to your point though, Ron, honestly, the hospitalization rate for acute measles is about 11 to 14%. So it will come. I've said.
Well, it's gonna be higher than 14%.
Well, that's what it's historically been.
But that's
So,
with existing immunization rates.
no, I'm sorry, that's with the current outbreak in the United States.
But
It's
as
10 to 14.
immunization rate falls,
Yeah.
that incidence occurrence, well, sorry, I didn't mean to go
You're good.
down a rat hole.
I don't want to get.
Let's go to patient safety. Let's
Experience.
go to patient experience.
Nice transfer.
I'm Maureen Sullivan, and Jen Lassick is gonna help me to cover this content today. So we're going to talk about our reputation compared to our local market. We're going to talk about our participation rate, which we brought to you last year, and we're going to follow up and close the loop on that. OAS, which is outpatient and ambulatory surgery, that's going to be publicly reported this month. There's a note on CMS because of the shutdown, it may be delayed, but that will be coming. So we have some good news there to share. And then how are we improving the patient experience overall? And lastly, talking about our Patient and Family Advisory Council and how we use them to help us shape what we do every day. So we go to the next slide, please. So for our reputation, I'm not going to go through all of these. You might recall last year, we shared where we're at compared to Cleveland Clinic and University Hospitals. I'm happy to report, thanks to nursing and the great efforts. Nurse communication, this green box means we are #1 compared to our 2 local other hospitals, and everything else stays the same. You know, Candy and the team. So just wanted to share that, and we're keeping an eye on it. Again, we're still 3 stars. Based on our calculations, it should go up one of these times when we're quarterly reported. So if we go to the next slide, participation. So as you all know, if you notice on the previous slide, it was 13%, kind of low. We really wanted more voices, and we want diverse voices. We want to make sure. So CMS gave us the opportunity to have some different modes, which we brought to you last year. You endorsed that idea, so we've done that. So starting in Q4 of last year, we started to survey patients for HCAS with web. And then in January of this current year, we started phone outreach, which costs us a little bit more money, but we believe that the value is there. So the results are that basically the response rate has gone up overall. We're at 18.5%. So that was a 5% increase in that 9 months, which is really nice. And every demographic except the 65 and over went up. So we're getting more diverse voices, which is really important so that we know how we're doing when we do our various improvement initiatives. Next slide, please. This is that same data. I'm in the interest of picking up a little time, what I just shared. So you can see the red is 65 and over based on age. So we broke down our demographics. Everything is up with these new modes of surveying. We go to the next slide. It's slicing it by the different mail, web, and phone. And again, our patients love the phone. It's more costly, it's more labor intensive, but they give us feedback when we call them and walk them through the questions. So and there's one more that looks at just all the different demographics that we look at, and all but the one are higher compared to last year at this time. So we think we made a good decision. We feel like it was a good investment, a small investment, and that we're getting the return that we wanted. So if we go to the next one, and we're going to talk about outpatient ambulatory surgery. So again, when this is publicly reported, just like HCAS, we've been working very hard. Katrina Conine and her team, Dr. Golub and our teams have been working on various different ways, improving processes, service, communication, and we're seeing green means good compared to last year. We've had a lot of great improvements in how our patients understand surgery, what to expect, what to do afterwards, how we're managing pain, how we're communicating with them. So I'm not going to go through all the questions, but you can tell there's a couple areas we're still working on. They're still red. Anesthesia and the side effects is one of them. And then some courtesy and respect with our check-in folks. So we're still working on that piece, but have some good interventions in place for that. We go to the next one. So a lot of this has to do with the written materials and our verbal communication. So we redid our guide so patients know what to expect. And we've also looked at our discharge summary. So we get them coming before they come in for surgery. And then when they leave, they know what to expect from us and when to call us and how to manage their pain and everything. And that's really been the key interventions that have helped us get into the green that we shared. And I think, is there one more? Okay. A lot of our work in general, talk more about it, as our theme of the year has really been about empathy and how do we help our patients feel like we understand them, we are listening to them, we support them. And we did some work in the surgery and procedural areas, and we've seen some improvement, not as much as we'd like to see, around clerks being perceived as helpful and respectful when they check in and when they are getting updates from their families. Jen's going to talk some more about more of that we've done in many areas and how we're doing in that regard. I think that's it, right? Oh, okay. Cleanliness, where's Brian, is another focus. We've done a lot of work in the procedural areas and seen some improvements. We're hoping to bring that over to inpatient and also the ED to make sure that we're improving those scores as well. And I think that's the last one, right? Okay, turn it to Jen.
Jen. Thanks, Maureen.
So to build upon that work, we'll start with the emergency department, and we have been on a journey with our emergency department. We'd like to credit their leadership and the collaboration in this. So about a year and a half ago, we looked at how we could improve the experience in our emergency departments. So we looked at process improvements, culture, because we know if we have that engaged staff, it'll ultimately show in the patient care and experience that we provide. And we were really looking at some of the patient voice, some patient comments, and we thought it was time for some empathy. So we developed this curriculum, Empathy in Action. And the emergency department was the first group that we facilitated with. Next slide, please. So when we started to facilitate, we started to see a change in scores. So our two system goal metrics for the emergency department are rate emergency department and good communication between staff. If you remember, in 2023, 2024, this blue was pretty much all red with 1 to 2 stars. So we've been able to make improvements there. We're seeing more engaged staff. We're seeing comments from our patients regarding the compassionate care and caregivers that we have in our emergency department.
And I just want to add that that's unprecedented growth in a patient experience score. Seeing that type of percentage going from a 58 to a 65%. So the teams, both the patient experience team and the emergency department, have been celebrating this great success, and they've been able to continue. And when you go into the emergency department, it's actually palpable. It used to be a negative palpable when you walked in there. And now it's a palpable positive feeling from our staff. So just kudos to this group for the great work that they're doing in the emergency department as the really truly the front door to our organization.
Yes.
So I'm interested in your previous slide where you talked about defining empathy and sympathy. Strikes me it's really a continuum, not an absolute. And it's relative to the listener and the giver. So we've got a lot of variables at play. So how do you define it in that context? If that makes sense as a question.
Yeah, sure. So it's really understanding our patients, being present in the moment, and it's in the behaviors, right? The behaviors that we exhibit. So we may have empathy, but if we're not validating emotions and expressing that and listening, our patients will never know. And it's hard to do in an episodic care environment like the emergency department, but we do a lot of, role play and how would you respond using clinical vignettes that we've created from actual patient grievances and thinking, how could we have responded better to this, right? We have to remember sometimes patients are in emergency department having one of the worst days of their life, right? So it's reflective time too that our emergency department caregivers have that they can take back into this.
It's a challenge.
It is a challenge, but we have a great group. And again, we credit our leaders there in the emergency department, Michelle Dudas, Dr. Emmerman, for really collaborating on this journey together. And they've done a lot of great work to really engage their staff. They've had, employee of the month, things that really make cookouts, right? Things that really help to provide that team building. And again, like I said, that ultimately shows in the way we provide our care to our patients.
Thank you.
So building on the success of the emergency department, we're taking empathy and action into the inpatient areas. And thank you to Dr. Mori and her team in nursing professional development who have really partnered with us. And these are the objectives for the empathy session here. And so we're now offering this to the inpatient nursing staff. CEUs are offered, and we've built this into nurse education days in 2026. So looking at provider and doctor communication, truly focusing on the domain of communication, listen, explain, courtesy, and respect. We are partnering and collaborating with the internal medicine resident program. And our sponsors for this are Dr. Cook, who's our program director, Dr. Nikhil Patel, who's a hospitalist and one of our partners in patient experience, and Dr. Naller in the SIM Institute. So what we're really looking at is some easy best practices, introducing yourself, explaining your role, sharing what comes next, sitting at the eye level of the patient if we can. So really kind to incorporate some of these best practices in didactic as well as in sim. So this is our next collaboration. And the ambulatory improvements. So our approach is a multidisciplinary approach, looking at the key drivers that really help to build likelihood to recommend, which is what we want our patients to do when they leave us. So key drivers are communication about wait times, provider explain, and good communication between staff. Sorry, I'm so dry in my mouth. Working group 1, communication about delays and keeping patients informed. So we can acknowledge waits, but we want to make sure that our patients, they will be less frustrated when we acknowledge waits. I'm just gonna Thank you. So we know that patients will be less frustrated when we acknowledge the waits. So we're looking at how we can acknowledge wait times across the continuum of care. That's from the time of check-in until the patient sees the provider. Provider communication, we have a multidisciplinary group that's really looking at provider explain and provider listen and some of those best practices, and looking at relationship-centered communication, which is a communication course that we have here for our providers. And finally, good communication between providers and staff. We have an e-handoff that we're looking at to better explain the next phase across patient visit. So we have a steering committee that reports out monthly, and we have chair members, chairpersons who are on this steering committee, and we'll be tracking our progress then in some of these best practices. And this is our Patient and Family Advisor Council annual update. So you may remember the Patient and Family Advisory is a volunteer opportunity where patients and families share their experiences through lived experiences and provide input into how we could provide better care. So one of the core concepts of patient and family-centered care is collaboration. So this is a collaboration with our patients and families. Here are some examples of our patient and family advisor collaboration. In quality and safety, we worked closely with Stacy Booker and her team. Most recently, we went to this group to look at falls education and how we could better educate our patients around falls. We had some great engagement from our patient and family advisors with ideas of how to educate staff. Service excellence and communication. As I said, we developed our empathy training, and we used our patient and family advisors to help us build that curriculum. Technology user experience is always really important, right? We want to have that user experience for our patients to test out and be able to provide us with great insights of how we can improve some of the technology that we have here, such as MyChart, kiosks when you come into clinics.
Lucille Thomas, report to 2A, as an apple. Lucille Thomas, report to 2A. Thank you.
All right, Ms. Thomas. Storytelling, one of my favorites, right? To hear directly from our patients and families and to hear their experiences. So this past year for Nurse Education Day, we've had patients and families really kind of highlight what makes our nurses so great and the compassionate care that they provide. And any way that we could have our patients share directly with our caregivers is super helpful to hear directly from the patient. And as Maureen mentioned, patient education, the surgical guide, any education materials that we produce in the system, we want to have that input from our patients and families. And finally, care innovation and community improvement, CSIP, which is a quality improvement program for our Medicaid patients. We've collaborated with the other hospital systems in CSIP, and we're, have great engagement from our patients onto how to improve care. So again, it's going to our patients directly to hear through, lived experience. We do have a system council that meets monthly and has different topics that we have different stakeholders come to the system. And then we have smaller councils for more specific populations One being Pride, our Pride Patient and Family Advisory Council, Neurodevelopment Center Patient and Family Advisory Council, and our Old Brooklyn Senior Health Care Council. So again, we credit our leaders in these areas who've collaborated with us to form these councils to better improve care by hearing directly from our patients.
And the Patient Family Advisory Council was also involved in recent discussions regarding charity care.
Yeah.
And those pieces that.
Questions? There's starter language update next.
I will show the documents.
All right, thank you.
Thank you.
Thank you.
Correct.
I think this should be extremely quick and maybe even make up a few minutes here. Basically, the governance committee is putting forward for a vote for all of the committees and updating every single committee charter language. The language will, based on the different committee, insert your appropriate name here for the committee. All trustees are invited to attend the Quality, Safety, and Experience Committee meetings, but only members of the committee may vote on matters before the committee. And that is being added to, let me see this section. The composition section. So at the bottom of the screen, that language will be added by the governance committee. This is more of just an FYI. There's nothing to vote on here.
I think the governance committee has made a recommendation yet.
They are going to.
No, we have not. We have not.
They have not. They have not. They have
We're
not.
told that.
We're working on it.
Okay.
No, it's going,
Pass it on.
it's going to the governance committee.
And I would say we've recognized that's an item we really want to talk.
Right.
It was more of just an FYI of what's to come.
Decision was made to put it in the.
Got it.
We'll bring it to the-
Thanks for the update. So much for the time saved.
I'm glad everyone already knows about it.
Oh, yeah.
Next, we're going to move into executive session to discuss hospital trade secrets as defined by RC 133.61 and to consider the appointment, employment, dismissal, discipline, promotion, demotion, or compensation of a public employee, the investigation of charges or complaints against a public official, and to conference with the public body's attorney to discuss disputes involving the public body that are subject pending or imminent court action as defined by the Ohio Revised Code 121.22G. Do I have a motion to recess an executive session to discuss these matters?
So moved.
Do I have a second?
Second.
I'll do a roll call. Dr. Walker,
Yes.
Mr. Summers,
Yes.
Mr. Moss,
Yes.
Mr. Jazinski, yes. Okay, we will move in executive session.
And we are back in public session.
All right, with no further business to bring to committee, I would adjourn the meeting.
Thank you.
Thank you.
That's 2:58.
Okay.
Two.